algorithm for the managing the patello-femoral instability. Coming to the indications, in acute cases, the absolute indications are large osteochondral fragment or large osseous MPFL avulsions. Relative indications are the multiple anatomic risk factors and the history of contralateral dislocations that failed conservative management. These are the relative indications. So we'll start with the first time dislocation. If there is an arthrosis, hemarthrosis, we need to take an MRI to find out the large loose bodies, sometimes large cartilaginous loose bodies which cannot be seen in the radiograph. You need to take an MRI that is indicated in these cases. And if there is a large loose body, you need to repair, fix it and do a soft tissue stabilization. Most of these patello-femoral dislocations, 99% of the patient, they will have the MPFL tears. So you need to do a MPFL reconstruction when there is a loose body or some fixation inside the joint. If there is no arthrosis, need to find out the relative indication. These are the consensus statement and agreement and disagreement. A patient with a first time patellar dislocation in the absence of an operative osteochondral fracture or a lesion requires excision or repair should be treated non-operatively regardless of age or underlying bony anatomy. So any if there is no indication for excision or repair of the osteochondral fragment, you need to do non-operative treatment. If MRI demonstrates an operative osteochondral fracture or a lesion requiring excision or repair, and patellar instability should also be addressed with the osteochondral fragment fixation. A first time patellar dislocation should undergo MRI. This is a 66% of agreement. So comes to the smaller hemarthrosis, like the less swelling. These patients are low energy or non-contact injuries. There will be suspicion of abnormal anatomy, and you should have this patient will have a high risk for the recurrence. So this girl, if you see, so she is having a without injury, she is having a dislocation of patella. These patients need the further evaluation. This paper published in editorial commentary in the risk stratification in these patients. Like risk stratification is the new standard of care in the patello-femoral instability. And this paper published in AJSM in Danny and Dam et al. Has published the risk factors to evaluate the risk factor for the recurrence. And patient who has less than 25 years age with the dysplasia, there is a high chances of recurrence in 2 years. There is a 50% of recurrence in 2 years. And another one is a dysplasia plus alta. There is a high chance for recurrence 50% at 2 years of age. So patella alta and patella trochlear dysplasia, these are the two important things need to evaluate in these cases to avoid the recurrence in these patients. So these data shows there is a 60 to 70% patients who will have the 5 years recurrence for 60% in a younger age group, people younger than the 25 years. And the more than 25 years of age group, they will have the only 30 to 40%. And another paper, this is predictor of recurrent patellar instability in children and adolescents after first time dislocation. If you see the patella alta and trochlear dysplasia, skeletal immaturity and contralateral patellar dislocation, they evaluated there is a chance of the predicted risk of recurrence 88% if someone is having these all 4 risk factors. And if 3 risk factors are there, the predictive risk of recurrence is around 75%, and 2 risk factors are there is a predictive risk of 55%. You need to evaluate these patients thoroughly. And how to work up this patient? You need to take an X-ray and skyline view of knee joint and weight bearing X-rays and CT and an MRI. And the number one risk factor for the recurrence is trochlear dysplasia. So DiGeorge classified this classification depends on the morphology of the knee joint, type A, type B, type C, and type D. Type B and D are the severe morphological changes which needs, most of them needs surgery, some bony surgery. And he has done this classification by sulcus angle, taking in consideration of the trochlear depth and crossing sign, double contour sign. These need to be evaluated, and CD ratio shows the patellar height. CD ratio normally is 0.6 to 1.3. If it is more than 1.3, it is a pathological. And evaluate the coronal malalignment like TTTG ratio, TTTG distance. MRI you can find out in an MRI or CT. The normal is less than 15 mm, and the borderline is 15 to 20, and abnormal is more than 20. And you need to evaluate for the coronal malalignment like valgus, varus malalignments, and femoral anteversion also in a risk factor for the patellar instability, and ligamentous laxity, another risk factor. These are the things you need to evaluate. Coming to the algorithm, the DiGeorge type A and C trochlear dysplasia, which is a minimal, which are the minimal dysplasia, having less than 20 mm of TTTG distance with less than 1.2 mm of 1.2 CD ratio, and soft tissue procedure is enough for these patients. And trochlear dysplasia of A and C with a TTTG more than 20 need to do a tibial tubercle osteotomy. And type B and type D dysplasia more than 24 mm sulcus deepening trochleoplasty is needed, and type B, type D more than 24 mm trochleoplasty with TTO. And someone is having a patella alta, this is a significant patella alta, more than 1.4, needs distalization of the tibial tubercle. This is a trochlear dysplasia. And femoral anteversion is 12 degrees is normal. Tibial external torsion is 20 degrees is normal. Someone is having femoral anteversion exceeding 35 degrees, need to do derotation osteotomies. And external torsion of the tibia exceeding 50 degrees needs derotational osteotomy in the tibia. So to conclude, management of the patellar dislocation is still evolving, and MRI is needed for all dislocations. Majority of the patient can be treated non-operatively. Surgery for the patient with osteochondral loose bodies with a soft tissue stabilization. So risk stratification is very important in first-time dislocator, even recurrent dislocators, and consider the bony and soft tissue stabilization, high-risk individuals with abnormal morphology. Thank you.